So today we have our announcements on the agenda, and I have been charged with giving an update on what's happening with the CoCM grant from our executive meeting. And I can tell you that this meeting is happening prior to our executive CoCM meeting on the grant. So we meet on Monday, so I don't have a lot to report. Not much has changed since last time. I did want to remind everyone, though, year one for this SAMHSA grant will end on September 30th. So just keep that in mind. I know we've got our clinic partners on, and we want to make sure our clinic partners are aware that September 30th. So I'm sure Teresa Hudson and her team will be, I know Amanda Lumsford's on here, will be reaching out with more direction. But believe it or not, we're in mid-August, so we've got about 6 weeks left. And just want to say lots of different things are happening with that grant. I know Tisha's going to be on in a little while. She's going to give her update. And then we've also got our partner clinics on, and they are rock stars and they're moving right along. And so exciting things are happening with our FQHC clinics. So I don't know if anybody wants to add to that from any of our partner clinics. Any updates on what y'all are doing? And if not, that's okay too. I will just brag on them and say, I'm so happy Eastern Arkansas has hired a BHCM, and that's phenomenal. They're also interviewing another BHCM next week. So we are in the process of getting that going. And Boston Mountain has a BHCM on their team identified who's going to move into that role. And we're really excited about that. In preparation of them, we have been working on some BHCM training specifically to help with the onboarding process. So we'll be ready to go with that, hopefully mid-October-ish, after we get folks onboarded, started, and then we can start that training piece. Another quick update for our clinics, Eastern Arkansas. In particular, we have been, thought they had a psychiatrist, the psychiatrist backed out. And so now I just have to brag on and say thank you to Dr. Gibson, who has been casting a wide net and helping identify a psychiatric consultant for that project. So those are kind of,
I can give you a name as well. Ascend actually has really specialized in being psychiatric consultation for the FQHCs nationally. And so you could reach out to Josh and he could probably be helpful to you.
Do you mind sharing
I'll put his contact information in, but he actually is really working on this. I'll put it in now.
I thought it was really relevant. I mean, I just reached out to psychiatrists that I've met, and we have actually a collaborative care psychiatrist Facebook group and an APA listserv, and there's 6 or 7 that have specifically replied and said they're interested in hearing more. And so we're in the process of, we'll be matchmaking with the clinics, this clinic, and then any other clinics that do need to hire a psychiatrist.
Yeah, and I just put Josh's information in there, and they're kind of plug and play. So if they're helpful, reach out.
That's awesome. Thank you, Verna. And David Jones sent his apologies. Of course, you saw that, and he cannot be here today, so we're not gonna be getting an update from the state. But I wanted to, in saying that, wanted to just bring up that, uh, as we're moving through year one, um, there's a lot of question about, are all commercial payers paying for the CoCM codes in Arkansas? And we know that Blue Cross Blue Shield is doing that, and they've created a resource page, tip sheet with information specifically on CoCM, the codes, the reimbursement. But we know, and I have to thank Verna and give a shout out. She sent us an article, which I sent to you all, that talked about if all payers are not on board with paying for CoCM, it becomes really challenging in primary care spaces to pay for that. So then the question came up, are all of the commercial payers paying for CoCM?
Yes. The
I don't
answer is
know the
yes.
answer. In Arkansas.
Yes, I can actually give you a list and the payments. I can't share the rates because that's individual to contract, but I can tell you that payment has been received from all of them.
Fantastic.
Mm-hmm. I could probably give you a list of them. But yes.
Awesome. And then the next question, do we know if they have any tip sheets or support or resources for practices?
I could have someone check on that, who might know, but I'll have the list of payers pulled right now and I'll send it out to you, Kim, and then you can share it.
Perfect. That would be amazing. Yes. Just because we want to make sure that that is happening. And with that, I know, we've asked Dr. Gibson to give us a update on what's happening on the national scene, and she's out there doing a lot of these meetings. And so I know, Dr. Gibson, you've been busy meeting with different entities, and so didn't know if you want to take a moment and just give an update on some of the things that you've found.
And I know we have national people here with Verna and Sarah Burns, and Nicole actually also is from out of state. So y'all already know this, but actually this is the fourth meeting of my day that's been about CoCM. And so if there's any doubt in the state that CoCM is important and that people are still doing it, even though it's taken years, the evidence has been going on for years. I've actually had meetings with North Carolina, and there's a North Carolina collaborative consortium that's ongoing, and they're still sharing information about how things are going with North Carolina. Met with some people from Tennessee, and then people from Northwest, the Northwest part of the country, not necessarily U of W, but some of the payer groups up there. So it's encouraging, and it's interesting how some of the same exact questions come up that we're still needing to continue to share out what's working and what the best practices are. And Sarah, I saw you nodding your head there. And yes, in the last hour, I said concert, Prism, and my doula in the last hour. So just wanted to call that out, that all of y'all are great resources. And so it's good. So Arkansas is definitely on the right track. Consistently, everybody that I talked to said one of the major issues in beginning implementation, as well as sustainability, is the necessity to have all payers paying. If that primary care just has a struggle to be able to implement something if they have to choose which payers. So it's still really going to be important. I hope that Arkansas Medicaid will be able to turn on those codes soon, and all payers need to pay an adequate amount. So I'm glad that Arkansas Blue Cross is doing that, so I can keep my job there. So it's just been encouraging to me to see that it's still there, and that people are trying to figure out how to sustain it. The co-pays and cost sharing seems to be a continued barrier, so we want to try to find some solutions there. Someone told me yesterday, oh, well, a payer can just decide not to charge the copay. I do not know if if that's true when you're talking about these ERISA high deductible plans or not. But this is one of the things that we do want to try to
It is
find out.
actually true. There is precedence for it. Humana actually did it across their Medicare Advantage line. So it is possible to do it. It's just, it's not an easy lift given some of the, but yeah, they can actually do that. And we are trying to hit the US Preventative Task Force again to be able to try to change that.
I'll also add that Blue Cross Blue Shield of Michigan has waived all patient
Yeah.
cost sharing for most of their commercial products. There, you know, some of the smaller employers or larger employers who can choose kind of line by line what they're covered when they're negotiating for health insurance, but the vast majority of Blue Cross Blue Shield products don't require any patient cost sharing.
In Michigan.
Correct, in Michigan.
Yeah, so those are the kind of best practices. And I know that payers need to hear what are the pros and cons of that and the cost of that. So that's important info for us all to have. So that's the main thing. And I would just encourage people to register for CFHA conference in San Antonio in October, because there's going to be quite a few CoCM presentations, and there's a real effort within CFHA to have multiple models covered and to incorporate all the different disciplines, get more physicians and more primary care doctors involved so that they can learn part there too. So I'm having fun.
Definitely staying busy. Yeah, Verna, thank you so much for sending us that article. I think that that was really helpful because for me, the biggest takeaway is if we make billing really complicated and we have certain payers that are paying, certain payers that are not. You know, as you said, Humana, they're waiving cost sharing on this across the board. It becomes really challenging for the billing departments, really challenging for the primary care providers. I don't know if you could comment or if you have any thoughts or on solutions. Because it sounds like two things. One, in Arkansas, we need all payers to pay for CoCM codes, and then we need to remove the cost sharing barriers. That's what I'm hearing.
Yeah, I would also say there's a big advocacy push, and I was going to share with you, Kim, and Sarah's probably working on this on her side to advocate for CMS to change the use of the G0512 for FQHCs for Medicare and actually have them use the CPT codes. So I'd be glad to share those advocacy points, and if people, you know, wanted to put in some public comment, I think that would be incredibly helpful as well.
I also just put a link in the chat to a report. The report was written by North Carolina Medicaid, but it's kind of on behalf of their state coalition that was working on collaborative care. If you haven't seen it, really helpful. They talk about how they got insurers to remove copays for CoCM and some of these same issues, you know, on a kind of a statewide level. So take a look at their report.
Is that the roadmap one, Sarah?
Yes. Collaborative care model in North Carolina, a roadmap for statewide capacity building to integrate physical and behavioral health care.
That would be helpful. I know we've met with Dr. Dowler, their Medicaid director, and she's really been a champion for helping that happen in North Carolina. And they had such a just seemed like such a phenomenal group of advocates. So that's, I think, part of what we need, right? We hear we need champions. And so here we have in Arkansas, this group, and we can be the champion. We are the champion. So these are great resources, and we'll get those resources out and keep working towards that, because we don't need to invent the wheel, but we can learn and look at what are other people doing, and try and replicate some of that here.
I also think maybe some advocacy and barriers, I know on our end, is the requirement for the physicians to have to document the consent. I know that there's been some talk about that going away, and any team member can document the consent. I mean, I think consent is incredibly important. I just think trying to get our doctors to do any more things creates problems. So that's another
That's
piece.
going to get changed. It'll probably be changed in early 2025. Actually, just had a back and forth with CMS around that, and we gave them some language. So I think you're going to see that changed.
That would be great.
That's awesome. You're right, Tisha, though. That's another thing we hear. We don't want to put any more pressure or responsibilities and duties just on the primary care provider, because they can't keep up. And the more
I mean, when you think about like adding other team members, like they don't have to put in consent to have them talk to the dietitian or a pharmacist, or like to bring in other team members, that's not, I mean, so I just feel like it's an added step that's not necessary.
One of the things I actually heard earlier today about one of the places for consent is to make sure the patient understands what will happen, that they may have a copay, or they may, that they're going to be called on the phone, or so that they understand, what does this model look like, and that their PCP will continue to. So that can be part of the consent process. Not that it has to be clunky in terms of having to write a note, but
I mean, I'm not advocating for not consent. I just think the requirement that it has to be documented by the PCP creates the issue that a lot of times, like they will help people to understand, but we do a lot of the consent process. And so as far as the real explaining.
All right. No. And then we've got our update from Tisha for UAMS and all the awesome things that you guys are doing.
Hello. Sorry for being late, and I apologize in advance. I just got out of a 3-hour meeting about coding and revenue generation in primary care, so my brain's a little tired.
That sounds like fun.
Always exciting.
On a Friday. Oh.
Yeah. So, but things are going really, really great here at UAMS. We have our two new behavioral health care managers, Khadijah and Jennifer, who are onboarded and working and calling patients, and we are working with the evaluation team to get them enrolled and evaluated. Still kind of waiting for them to give us the red cap stuff to start implementing or bringing patients in, but they are working and really just magnificent. I'm so excited about them. We also have 2 other behavioral health care manager jobs posted. And so already got some applicants. So in the process of weeding through the applications and then trying to get 2 more onboarded. So we are really excited about that. We are also working closely with PRI, our Psychiatric Research Institute, to bring on a second psychiatrist who I'm really excited about. He is actually he lives in Texas, Dr. Sokol, but he has worked at UAMS before and done remote work and is really, he's knowledgeable about collaborative care and excited to work with us. So we should be able to have 2 psychiatrists and 4 behavioral health care managers up in the next few months. So very excited about that. And I don't know. Any other things you guys wanted to hear about? That's been a lot.
I can say that Tisha's gonna be, and I say this with all the love in the world, my official guinea pig to try out a new pro forma that we built. Actually met with Ames the other day. We talked about a little bit and we're building it. So next week, Tisha's gonna be my official guinea pig to walk through it. So Tisha, I'll send you a list of things you'll need to have and we're gonna plug them in and hopefully we'll be good.
Excited, yes. I am excited about that. I think, one of the things that I have said from the get-go with this grant is I do not want to just hire a bunch of people with grant money and then the grant go away and us not be able to support them financially. So I'm really excited about kind of getting the numbers right, recognizing who we need, and also having the numbers to be able to show Medicaid, because we have a huge Medicaid population and this is just not going to be sustainable at UAMS unless Medicaid pays for it. And so I feel like that having the pro forma, being able to show kind of like sustainability versus non-sustainability, given our payer mix, is going to be really important. So, and I think now with having some people on board and, having some numbers to plug in, it's going to be really helpful. So I'm excited.
Absolutely. I think, Tisha, not just for UAMS, but I think once the FQHCs get up and rolling, I think it's important to do that as well, just so that the more we could show Medicaid and all of the payers really how this is effective, and then the positive outcomes. Maybe we see decreased utilization of other services. I think that this is going to be a really, really key piece. So especially, I know we've got Teresa Hudson on here. And Teresa, I know sustainability is a big part of this. And so in order to sustain the program, we have to show that practices can financially afford to keep the staff that they've hired through this process.
Yeah, so this is a particularly timely topic because at the end of each grant year, we have to turn in a sort of plan/report about sustainability in the state. Mm-hmm. So this is a big deal. We've tried to structure the funding so that a clinic can sort of have some time to hire, get people in place, and theoretically figure out, well, who am I billing? Can I afford to keep these people? Who doesn't pay? How do I, what is the barrier there? So that we can work on that, and so that we can report back to SAMHSA where we're seeing barriers to sustainability. So that's a pretty big topic.
Yeah, I think there's a couple of important pieces. One is, of course, Medicaid not paying, right? And how that impacts, and then how that impacts the ability to be sustainable in terms of caseloads. I also think where you're going to see, and they're having this experience in North Carolina, is while Medicaid is paying 120% there of Medicare, the commercial plans have not. And so that if places have a high commercial payer mix, while the commercial plans are paying, some of them, particularly in the smaller practices, are paying substantially below Medicare. And that also makes it difficult, especially when you figure in copays. So I think it's going to be a little bit two-pronged.
It's going to be it's one of the major challenges that it's on my list to really talk more with you all about how to overcome it, because Medicaid, SAMHSA was very clear at the outset of this grant that it expects to see some kind of plan for sustainability result, and it wants to watch it develop over 5 years, apparently, because we turn in one every year.
Mm-hmm.
So it sounds like, looking at Medicaid paying, not paying currently, but we need them to pay, and then the copay issue, kind of that two-pronged piece.
That's right.
Because, right now with the grant, we've got some flexibility, but when the grant's over, if we talk to patients about the program, sometimes if there is a double copay, or, patients are struggling with, should I participate? Can I afford another copay? So.
Right. It's in fact, I probably should talk to our evaluation director about making sure we understand whether there are patients that opt out related to copay, that say, no, I don't want to participate. And so I need to check in to what extent. Every time you want more information, you're burdening someone with giving you that information. And so the extent to which we can get that in a timely, in an easy way without burdening anyone unduly, is important to consider. But if we had that information, we could make sure whether or not that's a barrier, at least in our state.
Absolutely. As far as other states, thoughts on how I know, Sarah, you said there's the article with the roadmap, and we've met and sat down and talked with North Carolina. But
someone is at the front door.
Oh, sorry, guys.
Oh, no worries, Verna. Verna's got company. You're not alone, Verna. That's good. But thoughts with what happened in Michigan to get to the point to say we're waiving this cost sharing. And Sarah, I don't know if you were there at that point, but that would be helpful information to know.
Yeah, I can speak a little bit, although I don't have the magic answer. I'll say, I would recommend for any group, starting up collaborative care in their practice, create a way to track patients who decline to consent to be in the program, like Teresa was just saying. And, maybe there's a couple of drop-down options, and one of them might be, copay a cost or something like that. Other common, I'm sure Verna can speak to this too, because I believe they do track this at Concert from when I worked there, although I don't know what they're doing now. Other common reasons are people think they don't need it. Right. Oh, I'm fine. I'm not depressed. I don't need it. So there could be a couple of reasons that might just help you. To your actual question, I wasn't there when Blue Cross of Michigan decided to waive copays, but what I can say is they have done an incredible amount as a payer to encourage implementation and adoption of collaborative care. So in addition to waiving patient cost responsibility, they've provided financial incentives to practices and physician organizations that engage with us at PRISM for their training and technical assistance. They've also provided some financial assistance around, at the beginning, putting in place a registry or a systematic case review tool. whether that's from the AIM Center or, something in the EMR, if there were, edits or kind of custom coding or things that were needed from these individual practices. So there's a lot more that Blue Cross of Michigan, I think, has done beyond just the patient level. Obviously, that's a really important barrier too, but they tried to remove some of those barriers at the practice and the physician organization level as well. That may have been a hindrance to adoption of the model. I wish I had been there then. Unfortunately, I didn't join the team until a couple of years after that was already in place.
No worries. I was just kind of curious, kind of what some of the drivers were, but absolutely, their program there now, Blue Cross and Prism. I think the partnership, you guys are really one of the premier examples of what could happen when you come together and provide training and financial support and remove some of those barriers. So,
Yeah. I will also mention, not exactly to your question at all, but just in terms of other things, other states, what they're doing. And I live in Phoenix, so even though I work for the University of Michigan, I live in Arizona. Last year, Arizona passed a bill that included $1 million for collaborative care implementation. So they had one funding opportunity for a technical assistance provider, which is currently the AIM Center at University of Washington, and a corresponding opportunity for primary care practices to apply for funding to implement the model. So kind of points of advocacy that could be possible for Arkansas, in addition to getting all the payers to waive patient cost sharing, getting Medicaid to even cover the codes and cover them at rates that are high enough to matter. There could be a way to advocate for state level funding, to alleviate some of the barriers for practices to sign on as well, like Arizona's done. Unfortunately, Arizona only gave 3 awards, and I think they only had 4 primary care practices apply. So my hope is that when it opens again this year or next year, that the opportunity is more widely circulated. So more practices that are eligible know that they could apply.
good to know. This week I happened to be on a call, and one of the things, because you're pointing out, 4 practices applied and 3 were awarded. So this huge state, tons of primary care practices, not a lot of applicants. And one of the questions was, how do we generate interest, and how do we find practices to participate when we know primary care providers are feeling overworked and overburdened and stressed? They talked about, primary care providers are struggling with pajama time, meaning they work all day, they see their patients, they come home, they do their household duties, and then when they get in their pajamas before they can go to bed at night, they have to stay up and do all the things that are needed. And so when we're asking them to do one more thing, that can be really a challenge. Any thoughts, Verna or Nicole or anybody, Bree, anybody who's been working with different practices on how you're convincing primary care practices to do this model? I know, Verna, I was on the CFHA call this week, and they talked about Concert has just passed seeing their 100,000th patient, I think, which, wow. So I'm guessing you all have some suggestions for this. How do we convince, and how do we support, besides financially, primary care providers when convincing them?
My very basic thought is go to present at their annual conferences. That, often I'm presenting at the behavioral health conference, which is not where the primary care people are. And I wonder, well, why aren't we getting the right people who want this? Whatever the, family medicine conferences in Arkansas, we presented to the one in Michigan, similar for the, pediatrics, things like that, put something in at those annual conferences and see what kind of interest you get.
It's a great idea. So reaching out, typically we do have the AAFP on here. So, and I know Dr. Gibson has presented for the AAFP past couple of years. And I know CoCM was a huge topic at the APA conference. Dr. Gibson brought in Dr. Beecroft, who is here in person. So I think some of that starting to happen, but really taking a look at how do we continue that reach. Other thoughts, things that you guys at UAMS might be doing as far as how are you convincing your primary care providers to adopt
I mean,
the
I think all of our primary care clinics are very much wanting to do it, but I mean, it's for them not an individual decision, really. It's a system decision that's been made. So they aren't really having to think about implementing it on their own. I think that's some of the struggles with primary care, like individual practices or places that are, that's all they do is primary care is okay, like they've already got a lot of stuff. And the idea of implementing a program and, finding behavioral health care managers and psychiatrists to work with and, that's it's a big push.
Absolutely.
I know for us at Mercy, I mean, obviously we already have the primary care providers. We can easily get their attention. But it does vary state to state on who's engaged and who isn't. And so for some of those clinics where we've had less engagement, going in and talking to them. And sometimes it's just really, really basic things that they either misunderstood or you need to talk through, like, why don't you write the prescriptions for me? I don't want to manage those meds. Why don't you just write it for me? That's always a big one you hear. But then, it's like, well, I won't do benzos. So then you start talking about some of those pieces. Well, you don't have to. If it's a medication you don't want to use, reach back out to that consulting psychiatrist and have a conversation about it. It's like little things, there's shared liability there as well. This doctor isn't kind of on their own prescribing something they know nothing about blindly. There's that shared liability piece. There's different things like that I don't think are traditionally truly explored in presentations in that way. And I think that that's where that lack of understanding goes a lot of times, is that they don't see there's just very, very basic questions. I know even for us at Mercy changed the way they do their RVUs and such. And my counterpart with Concert, her and I went into a clinic that morning and they're like, yeah, we're not referring to you guys anymore. Sorry. And I'm like, what? And it was the RVU change. And the way that it was printing out, we printed as a negative line item, but it did not explain how that negative line item worked. All it just said was a negative line item with collaborative care. It's a net zero because we're providing the service, it's taken out. But there's little bitty things, I think, along the way that sometimes as clinicians or administrators, we're not necessarily asking those questions or we're not sharing that information. And it wasn't until, boots on the ground, Sydney and I last year, I mean, we visited over 200 clinics just to kind of, yeah, I know, right?
Wow.
And I don't think we've bounced back from that, quite frankly. Even still all
Yeah.
this time later, like if you had to, guess.
Yeah, it was especially Oklahoma was really hit hard with that. Like we had to go back in and we had special meetings from it, all sorts of stuff. It was huge trying to get those physicians to understand that there was not they weren't losing money by referring to collaborative care.
Yeah. If you ever wonder, like you don't think physicians read anything, send them something about the RVUs.
Yep.
Attach it to that memo. Yeah.
So
Yeah.
a question, this is a little bit of a segue, but important piece. I have heard from another system in the state that they were going to implement our CoCM, but the system saw how many RVUs were assigned to CoCM codes for the PCP, and the PCPs were being reimbursed based on their RVU production. And so the PCPs were all about it, but the system was like, no, we can't afford. The system didn't want to implement it because they didn't want to pay the RVUs. Are y'all running into that anywhere else? Sounds like Mercy just said we're not paying those RVUs because we're providing the concert service.
Yeah, we're providing, I mean, we're doing, and by we, I'm including concert, but we're doing that care. We're providing that care for the patient, not the provider, even though it's billed under them. So that's how we've kind of explained that out. I know that there's a lot of places who do partial RVU to providers. And that's something that was talked about at one point. How could we do that? And that might be something that we're able to do in the future. I would love to see that because I do think if they have a little bit more of a stake in it, they look at it a little differently.
It just seems weird that the RVUs would be so extraordinarily high. Verna, do you have a comment on that? I mean, the RVU total does not seem to match the time and effort that the PCP has to do.
No, and CMS admits they kind of got it wrong.
Okay.
So, you know, also one thing that I think is important to think about is when you're asking, you know, systems or especially like smaller or, you know, rural primary care groups to do this, and all the payers don't pay for it. I mean, why in the world would they?
They can't.
They
If
can't.
it doesn't
Like,
go across their payer mix, they can't do it. If Medicaid doesn't pay and they have any Medicaid patients, they can't do this.
yeah,
Yeah.
I know. So it's like, how do you encourage? It's like, well, you can't like ask a group, somebody to do something that's gonna not, it's gonna, you know, not pay, and for them to not be able to get paid to do the job, the work they're doing, because it's a big initial expense, just as far as like time and energy and thinking
Absolutely.
through things.
Well, and I think too, our FQHC clinics that are participating in this, FQHCs, we know traditionally they're often a safety net. And so we're working with 2 rural FQHCs who are working as a safety net. And there's high numbers of Medicaid. So we, hopefully once the visits start happening, we'll be able to show this is how many patients have been seen that would have billed Medicaid. And so showing that. But I think also reassuring Medicaid that this will probably initially be a slow start, a slow uptick by clinics, and the amount of billing happening will probably be small initially. Just a thought.
But and also the effectiveness, like
Absolutely.
people are going to get seen and they're going to get better.
Decreasing the utilization of additional needed services because people are stabilized and they don't need any higher levels of care. Okay. I know we're getting near the top of the hour. I didn't know if anybody else had any comments or thoughts on that.
I was just going to echo what a lot of people were saying. I think when I'm not personally on the account management team, but I work very closely with them and have participated in a lot of the training and orientation meetings. I have found that like when the team does boots on the ground is in person, it definitely has a bigger impact and builds a stronger working relationship with those practices, especially as like a virtual service. We really need to lean into those opportunities. And I really think like it's not just about that initial meeting. It's easy to sell a product up front, but you need to sustain that relationship and build that trust over time. So something that I think is a really big thing that no one really likes to talk about is just owning mistakes. Hey, you mess up, let's talk about it. Let's own the fact that we didn't hit the head on the nail the first time, especially since there's so many opportunities to work with different specialties, different types of care providers in this field. We're not going to hit it on the nail every single time. We're going to learn as, we're flying the plane, we're going to be building it. And, really building that trust and that relationship and that strong working relationship facilitates a lot of those direct, honest conversations where we work to do better each time. So I think that is something that for me is where I see a lot of impact happen. There's a couple other things in mind, but my brain is starting to lag on Friday afternoon right after housing a lasagna mid-meeting. Sorry for being camera off, by the way. Didn't think anyone needed to see that. But those are some of the bigger points. And then I think that sustainability in the sense of like not just doing an initial training on this, but having regular touch points, reviewing referrals, the type of referrals that come through that are successful, reviewing the patient care, the results that come out of that, and just a lot of other items, making sure there's a constant feedback point, and then an ongoing learning space for the providers. They probably refer to a bunch of different entities for behavioral health, but they're probably only referring to one collaborative care unit. But collaborative care often gets mixed up with the definition of a therapist, a psychiatrist. So by the time the patient gets to us, they're like, oh, you're our therapist. And we're like, not exactly. So, I think that ongoing education component can be helpful too.
I also think giving people language, providers of all types that say, gosh, we've learned a lot about behavioral health treatment and we've learned that it's better in doses. So like doses of what you might think of as therapy or like, doses of treatment so that, yes, it's just going to look different because we don't care for cancer the same way we did 5 years ago. Like we've learned a lot. Well, we've learned a lot about caring for people who are feeling sad like you have for a really long time. And so like, because I think the initial instinct is, oh, it's not therapy, it's this. And just to say, well, actually, we're using the same evidence-based tools. We use our DBT and our CBT and our MI and all those acronyms in our tool belt. We're just doing it at a different cadence. And so I think it's a big shift for people to really, oh, wait a minute, I actually get that. So that they're right away saying, oh, it's not that.
Yeah, absolutely. I love that analogy too. I think reframing it for providers can be really helpful. And I've definitely seen where like you almost get too complex and like trying to break down what collaborative care is. Sometimes you got to pull back and just simplify it and be like, listen, this is what we do, and this is why it's better. Like,
Yeah, I would even say, why do we feel compelled to tell people what it is? Like, I understand PCPs need to know the difference, right? So they can understand the population health approach. But why do we feel the need to like tell patients like it's this and it's this? If you sat down with me today and I was in a community mental health center, I wouldn't go, so this is mental health treatment and this was, I would just care for you because my job is to diagnose and treat you. Like, why don't we just do that?
yeah, I would
And I
agree.
think that's a huge barrier,
Absolutely.
Yeah.
Focusing a little bit more on what we're here to do and who we are versus what we're not, going
Yeah.
into the session and being like, just to make sure everyone knows I'm not your therapist is not a great way to start a relationship.
This is great treatment and it's not therapy and it's not great. Thanks for telling me what it's not. All I want to do is get better,
Yeah.
like I'm out. Yeah.
Those are awesome tips. Caitlin, I want to give you an opportunity to share with us some of the upcoming events and things that are going on.
Yeah, I've got a couple of things that are coming up. Let's see if I can share my screen and work it correctly. Okay. So there's a couple of events going on and then just some revolving meetings that are happening that we just wanted to bring to your attention. The first one here is the AIM Center. They have, which we obviously all know the AIM Center, but they have monthly office hours that are going on right now. One's on implementation and another one on finance. So if you are able to check in on those, you'll probably get a whole lot of good information from them. Let's see, put that in the chat. That looks like it's happening the third Thursday of every month. And those are, if you go to that page that I just put in the chat, you're able just to get straight to the Zoom platform for that. So I think it's pretty unique that they have a finance option, because that's dominated most of our conversation today, as it should, because it is a barrier. So I'm glad that they're having that conversation. Okay, what else do we have? Let me stop sharing for just a second. It's kind of hard to see everything at the same time. Okay, so what we also have going on is the CFHA conference in October. That registration is still going on, but they also have their own monthly series. I think it's on Wednesdays though at noon. That you do have to be a member to attend, so you would have to sign up on their website, but those are absolutely worth signing up for. Great conversation. It's, I think right now they're having conversations about different vendors and just conversations about how everyone is implementing this in the different parts of the country. So and then of course, like I said, their conference is going on. Several people on the call are going to be presenting at it, so you'll be rubbing elbows with them as well. Let's see here. What else do we have? We also have, as far as an event, we've got the 50th annual Behavioral Health Institute conference going on in Hot Springs this month. And this has got again a lot of people that we know presenting on it. This is a glance at their schedule. It is jam packed. I think it's 3 days worth of conversation. And there are several presentations going on about integrated health and CoCM. So even if you're going for something else, there's ample opportunity to have conversations about this as well. I know Kim's going to be there, and a lot of people are planning on going. I think it's going to be a great time.
Zero Overdose is going to be there as well. We're actually doing something for the first time in the state on overdose safety planning.
Woohoo! That's so exciting. I saw your name on there and I was like, wait, I didn't know she was going to be here.
I'm actually someone else from Zero Overdose is coming. I can't be there, but we're going to be doing overdose safety planning.
Be there in spirit. That is so exciting.
Mm-hmm.
Wow. Okay. Registration is still going on there. And you can register via this link. And then Michael mentioned, or he may have mentioned right before I got on, or maybe as I was getting on. This is going on as well in October, where they're going to, like you said, this author's going to be there, but there's also going to be a panel discussion about this. And if it's anything like signing up for the schizophrenia conference, then you probably want to do it quickly, because those tickets went fast. So it seems to be a trend with PRI. They got a lot of stuff going on. And you can sign up via this QR code that looks a little funny right now, but yeah, we'll email it out and it'll look right. And that's going to be at the Robinson Theater downtown off of the River Market. So it's a very nice venue. It's nice to get out in that area anyway. So why not come in and listen to someone talk about some good stuff for Arkansas. I think I've covered most of it. We do have just a plug there. We do have our CoCM office hours that we began last month. That's going to be again this month, but the last week of August. It's the last Friday. It's going to be the 30th at noon. We've sent out the link for that and that, but if anyone's not on that mailing list or you would like to be included on it, just send me a chat here or just email me and I'll make sure you get that link so you can join us on the 30th. Kim, am I missing anything, or anyone else on the call? Did I miss any events?
I shared something in the link. We just put out a report on suicide risk reduction and collaborative care. I put it out on the CFHA listserv, but if folks didn't see it, I put it along with a pathway. And then Laura Sidari, who some of you know, she spoke at your conference. Her and I just finished a white paper on a call to action for pediatric providers and suicide that I'll probably post later today in the CFHA West listserv. So there's a lot happening around just, suicide and collaborative care. So just sharing all of those.
Thank you so much. Super helpful. And we'll make sure that we include these links. Well, I say we, Misty, who keeps this all together, will send out that email along with the minutes and that, and she'll include all those. So I think that's it. That's it for me, Kim.
Awesome. Thank you, Caitlin. And I just have to say, for those of you who are out there talking to primary care practices, please help us advertise those office hours. We want anybody interested in CoCM anywhere in Arkansas or beyond to please join us, because really it takes all of us coming together, sharing what we've learned, sharing our expertises, sharing our successes, sharing opportunities to retry things. And as Nicole said, we don't have to get everything right the first time. We can make mistakes, and let's keep coming back together and trying again. And I'm excited. From the office hours, we actually had a practice in McGee, Arkansas. They sent, I think, 5 people from their practice to ask questions about collaborative care. They were so interested and so excited. So we're reaching small little practices in rural areas across places that might never have access to these resources. So this work is happening, and thank you all for sharing your expertise and knowledge, because this wouldn't be happening without all of you. So thanks so much, and we'll see you guys next month.